Okay, so we're still admitting people as they're coming into the waiting room. What I might do is to not take up anyone's time. We might start the seminar very briefly. What I'll do is I'll give a brief introduction. I'll do a brief screen show as to some of the work that Mag and some of our partners are doing, and then I'll hand over to Nicole. And then as more people join Nicole, I'll admit them to the seminar throughout whilst you're speaking. So what I'll do, I'll share my screen very briefly. And one of the things that Mag and its partner business ICS are currently working on is our software business. So Insurance and Compensation Services is both a software and a data and analytics business related to the personal injury industry. And what I'll do a very brief overview as to some of the products and services that we're offering at the moment. So Insurance and Compensation Services, we deliver a range of software solutions to the insurance and personal injury industry. Some of our clients, including MAG and other medical legal providers, use our flagship ICS Connect platform, and that's mainly aimed at medical legal software providers. Some of our additional products include, we have some telehealth solutions, and interestingly, we're working on some AI tools to assist both claims managers and solicitors in resolving and having accurate data analysis for personal injury claims with historical data analysis focus. Some of our really interesting AI and machine learning solutions are based around the medical billing and invoice approval for surgery. Various compensation schemes across Australia have, different abilities and different agencies through which they approve these quotes, and it's a really critical issue for some of these insurance agencies and specialists. Some recent judgments by APRA or AHPRA highlight the need for specialists to have sufficient support to bill correctly in these convoluted and complicated compensation schemes. And we've developed a dual use tool to assist specialists to check their surgery quotes prior to sending to insurers, and for insurers to accept and verify those invoices. A piece of software that we're rolling out with law firms across Australia at the moment is what we call ICS Law Connect, and it's a fully customizable platform which assists law firms in their information gathering processes for all their medical legal reports, their hospital records, GP reports. We're providing modular service-based offerings and really jurisdiction-specific communications and reminders. Some of our other software solutions that we're looking at the moment that we're providing is an insurance-based software called Insure Connect, and that's designed at both self-insurers and large national insurers, and our Gov Connect, which is aimed at allowing government bodies to excel and manage compensation claims at an excellent service standard for their return to work outcomes. Some of our additional ICS solutions include some AI tools around financial calculations and PRW calculations, especially in New South Wales, and we're looking at some open source data analysis projects and some integrated telehealth solutions. Look, I don't want to take up too much of everyone's time, so what I'll do, I'll pass over to Nicole now to start the seminar, and as people join, I'll continue to admit them. So Nicole, over to you.
Thank you, Lachlan.
Okay.
Okay. So, hello everyone, and it's lovely to have lunch together. I'm assuming some of you are enjoying your lunch while we're having this chat. I think I might need my glasses on for this. I'm aware that we've got a variety of people here today. So look, I'm pretty big on destigmatizing psychiatry. So I think it'd be great if everyone today, when they've finished the talk, goes about their day telling people that they spent their lunch break with a psychiatrist and that it was fantastic. So that's how I'm starting off. That's who I am. We're going to have a bit of fun before we get into the heavy stuff. And I think psychiatry has quite a bad rap. And it was interesting when I was looking for a bit of humour, all the pictures that I found were all of male psychiatrists, either looking like Freud or looking somewhat crazy, with patients lying on a couch. And I didn't find any that actually represented me in my office, so a female with patients or clients sitting in a chair and looking relatively normal. So you'll see as we go through that we've got a few more slides that also have a similar feel to them. And this is, I guess, just to remind us that a lot of people prior to coming to an IME, they're pretty concerned about coming to a psychiatrist. They've seen that, you know, from movies, from media, that we can be either crazy or, what's the diagnosis here? Quite clearly a narcissistic personality disorder. And so I think it's just important to remember to, for case managers, for lawyers who are sending people for an IME, that they really prepare them well and explain to them what's going to happen in the session. Even simple things like, what is a psychiatrist? Because a lot of people don't know the difference between a psychiatrist and a psychologist, and that we won't be doing a physical examination, that we'll be doing a mental state examination, that we might be having to ask a lot of questions that they may not think is particularly relevant, and obviously to be honest and as truthful as possible. So I just thought you might like that one. Again, I think it represents a lot of feelings that people have when they come to see a psychiatrist, in the sense that they feel like they're being ripped open in some shape or form to tell us their innermost secrets. And I thought it might be interesting just to discuss a little bit about how we think about things, because for case managers and lawyers, this might be of interest to you. So most of us work in what we call the biopsychosocial approach. And this is really a holistic way of viewing mental illness. And it came about really by, in the 70s, a psychiatrist thinking that we really needed to bring together these groups of people that were either very brain-oriented or very mind-oriented, and bring it all together into a whole. And we use the biopsychosocial approach to think about causation and risk factors for mental illness, but also use this when we think about treatment. So I'll give you some examples of this. So in terms of causation, if we look at biological factors, we're obviously looking at things like genetics, family history. We're looking at whether a person has concurrent physical illness, chronic pain issues, what medications they're on. Psychological, we might be thinking of things like their pre-existing personality structure, the type of attachment that they have to others, their concurrent stress levels, and past history of trauma. The social side of it will be things like, what's their family structure like, what's their work situation like, what's their, what broader community are they in, cultural issues, etc. And we also then use this same approach when we're thinking about treating someone. So a lot of people think that psychiatrists just dish out drugs, and most of us do not work in that way whatsoever. We use a biopsychosocial approach and treatment so that we prescribe as required, but we do many, many other things, including various forms of psychotherapy, motivational coaching, lifestyle change, might be group therapy or relationship therapy, meditation, mindfulness training, and much, much more. The 4 Ps is another way of perhaps integrating some of our thinking into this. So we're always thinking about the predisposing factors, the precipitating factors, the perpetuating and the protective factors. And again, this can be gridded into the biopsychosocial approach. So for example, if we're seeing people for IMEs, we're looking at predisposing factors, what made them at risk for what happened. The precipitating factor is often something that might have happened in the workplace. What's keeping them unwell? And we've really got to think very, very deeply about this, because often issues within the system that they're in, whether it be work cover, issues at home, and abnormal illness behaviour, and sometimes just poor treatment or no treatment. And what are the protective factors as well? And that's always worth thinking about. I hope you all can guess what this diagnosis is. Anybody not get it? OCD. So, you know, we get issues that are really complex and take a long time. Again here, oh, we've got another male therapist also looking a bit crackers. And sometimes what we find out is actually quite simple, but we've got to ask the right questions to get there. Boundary issues, well, boundary issues are usually, when you see them in movies, etc., relating to crazy psychiatrists who might be having sex with their patients. But here we have a patient with boundary issues. Don't get too close. That's just to remind us that genetics plays a big part in mental illness. All right, so let's get on to the real stuff. So what's actually an independent medical examination and what isn't it? So, of course, it's got to be impartial. That goes without saying. Now, what does impartial mean? Well, we've got to be unbiased. We've got to be neutral. And when people come to us, they often don't understand this. They think that we're guns for hire. And again, I think it's really important to prepare people, because a lot of times they will come with quite a paranoid feel about what we're doing. We might have the power to sort of take them off their work cover benefits, or so I think it's very much important to explain what our role is before people rock up, and that it is medical, and that we have to have the right medical expertise to undertake these examinations. For psychiatry, we do what's called a mental state examination, and I'll discuss this a little bit further later, that we don't do a physical examination, and it's worthwhile obviously letting people know ahead of time that they won't be needing to bring in, for example, all their x-rays with them, and that they're not going to be touched physically. We have to abide by the expert witness code of conduct, and it's important to remember that what we write down is not protected and it's not privileged. And I always bear this in mind, because our reports obviously go out to who requested them, but they are often requested by the client themselves. So we have to be quite careful about what we write and how we write it. And my personal view on this is that, you know, if, for example, I've come up with a new diagnosis, and this is not uncommon. I might find that someone has a bipolar disorder that's never been diagnosed. You don't just want someone to get that from a medico-legal report. So there are ways that we can make sure that the client gets the information in an appropriate manner. It might be via their GP, for example. Other issues in that regard are if you think someone has a rip-roaring personality disorder, you can't just throw that in a report because somebody who reads that could be very distressed by it. So in those sort of cases, I might say things like there is a suggestion that there are some underlying issues with respect to personality or the way the person is functioning in the interpersonal space. But then I might pick up the phone and just explain this in more detail so that it's not necessarily in the report. So as compared to having a patient, it's not advocacy. We're not on anybody's side. We're not work cover investigators. So I often have to explain this to people when they first arrive. They have a lot of information that they want to provide, and some of it will be relevant for me, some of it will not. So if you explain this at the start, that you might have to interrupt them because this is a medical examination, and we do need the background story, but not to the degree that they would if they were having an investigation, then people don't sort of get upset later on down the track if you kind of go, hey, you know, that's probably enough on that particular area. We're not advising anybody directly about their treatment, but we are often asked to provide comment on treatment. And I find this actually a wonderful part of what we do, because so many people have not had appropriate treatment or any treatment. And if I can make some suggestions that then might go on to their GP or suggest that they actually be referred to a psychiatrist, I feel like, well, you know, we've helped in some way without actually being an advocate. And of course, be aware of conflicts of interest. So, but there are some similarities between an IME client and a patient, that in all cases, you have to obviously be respectful and establish rapport and validate and listen to their story, which will help establish rapport and therefore diminish some of the persecutor anxiety that people have prior to coming perhaps to their first IME. Again, you can make treatment recommendations, but they're indirect in the report versus direct, which can improve people's outcome. And it's all, you know, if people have a good experience with you, it is an opportunity to decrease the stigma of going to a psychiatrist, and it might actually propel them into getting some appropriate treatment. Now, this is a little thing I've put together about how we actually start thinking about doing an IME as a psychiatrist. So our left brain is very much our logical brain. It's the brain that's a problem solver. It's the scientific brain. And this is what kicks in when we first get the documentation. So when I start to read what's sent to me, I'm starting to put together a picture already of this person. I'm reading past independent medical reports. I'm interested to see what they have to say, but I'm not, I make my own opinion on things. And it's often interesting when there's a conflict of opinion with diagnosis. I'm often very interested in general practitioner notes, because that can give you a lot of information, particularly about timing and past history. For example, you can have someone who will give you a history, you know, I was bullied at work, I got mentally unwell. But when you go back over the general practitioner notes, you see that they went to the GP 6 months or 12 months before, clearly with depressive symptoms, and it appears that their functioning was declining. There was performance management, which they saw as bullying. So that's really significant when you're doing some of your work. The right brain, now what does that do? That's the creative brain, it's the holistic brain, it's the brain that senses things and feels things and integrates everything as a whole. Now, when that kicks in is when I go out to the waiting room to bring the client into my room, because I'm already sensing a number of things about the client. I'm looking at how they're seated. I'm looking at their affect, that's the expression on their face. I'm looking at bodily movements. I'm already getting an inherent feeling for what is going on for this person before they've even opened their mouth. And we continue to use the right brain along with the left brain when they're in our room. So the left brain is obviously listening to the information, is analysing it, putting it together, connecting it with past experience of stories that we've heard before and our experience in our work. But the right brain is also very much at work, because it's observing, it's seeing things underneath the surface, and it's feeling things. And I'm going to tell you now about our what psychiatrists call, what I call our superpower. Now, you can all have this superpower, and this is really a right brain experience, and it's what I guess we call countertransference. So when I've got someone in my room, I'm tuning in to what I am feeling about that person. And that is giving me a lot of information about how they are, in fact, managing and coping, and how others are responding to them outside of my room in the real world. I'm noticing, am I feeling irritated with them? Am I actually not really liking them? Am I feeling that I can't empathize with them? Am I feeling something's not quite right? And I'm tuning into that all of the time. And that's giving me information, perhaps that they've got a personality disorder, perhaps that they're trying to cover up stuff. So I'm constantly tuning in to what I'm feeling about that person. And then, of course, we get back to the left brain when we do our report, and we have to provide the information that we have synthesized into something that is understandable and readable by someone who's not a medical specialist, so that they get how we thought and how we came to our conclusions in an understandable manner. I'm going off topic here a bit, but this is mine, and it's sitting on my garden bench where I took the photo, and it just shows you how far we've come in psychiatry. Phrenology was a pseudoscience started in the 1800s by a physician called Gall, and then sort of reworked by the Fowler brothers sort of 50, 100 years later, which basically said, I'll show you another picture, that by looking at certain skull shapes and dents in the skull, you could tell certain things about people's brains. And over the years, this was actually used for job interviews, and also was clearly used in racial profiling as well. So that's the end of phrenology. Here's a picture of the brain, just shows you a little bit more about what I was talking about before, how the left brain is the analytical, logical brain, and the right brain is a bit more creative and holistic. So how do we diagnose? So we use currently the updated DSM, which is, we're now on DSM-5. And all of our psychiatric diagnoses are in there. The DSM is inherently flawed, but we have to put up with it because we need some way of communicating what we see so that it's understandable by other psychiatrists, other people in the legal field, so that we're talking about the same thing. It's kind of like shifting sands. Every time there's a DSM, new things are added, things are put together, things are taken out. It's somewhat concerning, but it's the best that we've got. So that's what we're using. These are the common conditions that we see, and you'll often see these in the medico-legal reports. Adjustment disorders are very common, and these are basically mental disorders that occur after a stressor, within about 3 months of the stressor, and that don't fulfill the criteria of another mental disorder. So these are often people that are, not sleeping well, feeling anxious, a bit down, not coping that well at work and at home, but and there's been a stressor, often a work-related stressor in the kind of work that we do. Major depressive disorder, of course, is very common and has clearly defined diagnostic criteria. Somatic symptom disorder is a real doozy. And we used to have a separate condition called chronic pain disorder, which now has been subsumed into the somatic symptom disorder group. So if someone has chronic pain, and again, we can't, when we're doing impairment assessments, we can't count chronic pain, but if there is a chronic pain disorder, we now call this somatic symptom disorder chronic pain type. And I'm going to talk a little bit later about the difficulties in dealing with chronic pain, because we often see chronic pain walk into our office doing IMEs. Post-traumatic stress disorder, again, has well-defined criteria. I think a couple of comments to make about this. I mean, I often see this both underdiagnosed and overdiagnosed. So in terms of overdiagnosis, I'll get, when I'm reading perhaps a letter of instruction that somebody's been diagnosed with post-traumatic stress disorder after some bullying at work. Well, they're not going to have developed that after some bullying at work, because that won't fulfill one of the criteria. But perhaps they've got anxiety or depression with features of traumatization, and we might put that in if they don't fulfill the full criteria. Where it's underdiagnosed, I often find people coming in with 3 diagnoses. So they come in with panic disorder, they come in with depression, they come in with anxiety. And if you look very carefully at their story, at the history and their symptoms, all of those symptoms are actually subsumed under post-traumatic stress disorder. So you don't need the 3 diagnoses if they have PTSD. Personality disorders are common, and they significantly affect the way people function. And you do need a longitudinal history to diagnose them. You also find it difficult to diagnose them in the setting of a serious mental disorder. However, often with our level of experience and using our superpower, we can tell if someone has significant personality dysfunction when they come into our office, and we can therefore again put this in our report, suggesting that there are factors other than a serious psychiatric disorder that it might be causing difficulties in a workplace, for example. Bipolar affective disorder I put in often missed, because I have picked up a number of people with bipolar disorder who have been referred with depression. And it's really just because people haven't asked the right questions about symptoms of mania or hypomania, which is a lesser form of mania. So the big thing here is, unless you ask the right questions, you're not going to come up with the right answers and the right diagnosis. Now, these are some of the difficulties that we come across as independent medical examiners and as psychiatrists in this field. Pre-existing psychiatric history can be minimised, and this is why collaborative evidence such as general practitioner notes can be very useful, because someone will often just say, oh, you know, this manager bullied me at work and it was terrible and I developed depression. But that was indeed not the case, and it was a bit more complex than that. Aggravation injuries are again tricky, but someone had a long-standing, let's say, psychiatric condition, maybe relatively well managed, maybe a bit symptomatic, and then something happens and they get worse. And you have to kind of work out, well, how were they functioning before? Was it as good as they were saying? You know, they've been on antidepressants for a long time. Perhaps they weren't quite as well. So you've got to try and sort of sort this out by really just doing an excellent history. Now, the whole history of the issue of bullying and performance management, of course, is one that we see often. And you can have appropriate performance management that causes psychiatric distress. You can also have bullying performance management. So you've got performance management and bullying, and you can have bullying that wasn't performance management. So it's all pretty complicated. Now, secondary versus non-secondary, we're not allowed to take into account, particularly when we're doing impairment assessments, secondary conditions secondary to physical disability. So let's say, for example, someone's had an accident, they're in chronic pain, they develop depression secondary to the chronic pain. That has to be excluded when we're looking at impairment. Non-secondary is kind of another way of saying primary. So something like you had a car accident, you develop post-traumatic stress disorder from the car accident, that would count for your impairment. Pain, I'm going to talk about later because that complicates everything. And of course, when you've got physical injuries, pain and psychological injuries all mushed up together, we've got quite a lot of stuff to sort out. Again, personality disorders makes things a bit more complicated, and abnormal illness behaviour, which I'm going to talk about separately because I think it's an interesting one for you guys to know a bit more about. The people that come in might lack insight, and they might be overestimating their capacity when really they're not doing very well at work at all, for example. And then you've also got to check out, well, what else is going on in their lives? And I'm thinking, particularly of workplace injuries, because there are lots of other things going on. And people's relationships might be breaking down. Someone's mother's died. And we, in the independent medical examination, have to kind of often tease out how significant were these factors and how significant was the factor that they've actually been referred for. It might be a medical negligence claim. It might be, an abuse claim. But there are obviously people's lives do not just stop because of these things, and we have to sort all these things out. Pain is very common, and there are a lot of ways of categorising pain. Pain that we often see as an IME is often chronic, and it's been called pain without a purpose because the acute injury is often gone, and then people are left with chronic pain, or there is no physical reason for it that can be found, nothing in the scans, and then people are told often by doctors that, well, there's nothing to find. They get very angry because they feel their pain is real. It's a complicated thing. We know, for example, that when we've looked at scans of people with arthritis, that you can have someone with a severe degree of arthritic change that has minimal or no pain at all, and someone that has very minimal arthritic changes can have quite a lot of pain. So you can see that pain is not just about damage to a tissue. So this is how common pain is. I just mentioned low back pain because I often see this written down like it's a diagnosis, person has low back pain. And it's actually not a diagnosis, it's a symptom, just like fatigue is not a diagnosis, but a symptom of a number of conditions, both physical and psychiatric. The brain can actually amplify pain. We know this now. And we often see these sort of chronic pain patients where, they might have had an initial injury, a car accident, they had, let's say, a whiplash, and then you see the pain has spread. So the next minute they've got pain down their shoulders, down their arms, down their legs. And this is very much about the role of the brain amplifying pain signals. We know that in depression, there is often pain, and we know that people with pain conditions often have depression, and that there's some symptom overlap as well. So we've got to take, again, a very good history when we're trying to sort out what's what in these people. And we've also got to think about what else is going on, because chronic pain patients will often catastrophize and feel helpless and demoralized. And there's often a fear of movement, which makes everything worse, and concurrent anxiety and depression. When people come into our office, we often see abnormal illness behaviour. And this was a concept that was discussed by a psychiatrist many years ago, and can involve a number of different responses to illness. And it's basically been defined as an inappropriate or maladaptive mode of perceiving, evaluating, or acting upon one's health, despite explanations by medical professionals. And there are certain risk factors, which I've put down there. And I think that this is worth looking at in a bit more detail. So we can have people that are overly focused on bodily symptoms, that's systematically focused, or under-focused. So we call that illness affirming if they are perhaps overly affirming their bodily symptoms. And that can be conscious, so that when we have people come into our office, you know, with the fake limp, I know a fake limp when I see one, or those kind of people that say, you know, their symptoms, particularly with pain, it's often interesting. You know, they look quite comfortable, they're sitting in the chair, and you ask them what their pain levels are from 0 to 10, and they say always 9. You just know that that's going to be a lot of rubbish. It can be unconscious. So they can have abnormal illness behaviour, but then it's coming from an unconscious place. So it's not a put on. And then they can deny their illness, both also conscious, because they want to make sure they keep their job, or they don't want treatment, or there's a shame of illness, or they can have unconscious mechanisms that cause them to deny their illness. And then we've got the same with the psychologically focused. So we've got illness affirming. So people can come into our office consciously putting on symptoms. They've looked up the diagnostic criteria. They know them all back to front for PTSD or depression, and they reel them all off. Or it can be unconscious. And then we've got the same thing with illness denying with respect to their symptoms. So it's just something in the independent medical examination that we've got to be aware of, and perhaps I think it's important to note down in our reports if we see that this is an issue. And here are some of the at-risk beliefs for people who have abnormal illness behaviour, and they often catastrophize and have low self-efficacy. Now, I'm just going to briefly mention how we assess impairment. In Victoria, we use the GEPIC. In New South Wales, there's the PERS, and other states will have their choices as well. It's important to note that these impairment tools have to be used by qualified medical people, and we are using the GEPIC along with the AMA guides. I'm going to show you, before I show you a GEPIC, just to be aware of what actually an impairment is. It's any loss or abnormality of psychological or anatomical structural function. There's the definition of permanent impairment. And I think it's just important to remember what the difference is between impairment and disability, because a disability is some type of restriction or lack resulting from an impairment, and this can vary person to person. So I just put down here a concert pianist who loses a little finger. Well, the impairment's only 1% because it's only a little finger, and yet for that concert pianist, the disability is going to be 100% because they can no longer perform their occupation. So what's a psychiatric impairment? So it's any loss of psychological or mental function. And we, in our mental state examination, we'll be looking at a number of things, including how someone's speaking, perception. It doesn't mean, I'm going to clarify perception here. It's not how they perceive the world around them or how they perceive me as a psychiatrist. This is more about particular way of viewing things in psychiatry that might be impaired with respect to things like hallucinations or abnormal ways of seeing the world. What's their judgment like, their mood, and that can be elevated, obviously, in mania or depressed. How is their thinking? Is it slowed down, for example, because in depression? Is it confused if they're psychotic? We have to assess their level of intellect to some degree, and most of us will do some brief cognitive testing, although it is not always 100% reliable in the setting of people being very anxious, and obviously assess their behaviour. Now, there's a lot of problems with measurement, with all of the above, and I'm just noticing the time, so I'm speeding through, and in particular, this issue of apportionment. We're often asked to apportion impairments, what was there previously, what's unrelated to a physical injury, what's related to a workplace injury, and what's related to other stressors going on. And this can be quite challenging, trying to put percentages on things. Here's a GEPIC for any of you that might be interested, and we have 5 classes, 6 categories, and then we end up with a final score. We take away scores for impairments that were unrelated to what we have to report upon. And here's a PERS form. It's interesting that the PERS looks and focuses a bit more, I think, on disability rather than impairment, and looks a lot more at things like how people are coping in their everyday life, rather than a more direct measurement, which I think the GEPIC is. It's also done with median values, and we have to add up scores and then put it on a table. But anyway, at the end of the day, you get a percentage of whole person impairment. And I think the other thing to point out with respect to psychiatric diagnoses, people have to be really, really significantly impaired, like bedridden and really doing very poorly, to get a score that's relatively high, which you often need 30% for TAC or 10% for Wrongs Act, etc. It's quite difficult to get a very high score with these assessments. I wanted to leave enough time for questions, so I just wanted to show you a picture of a law office with a shark on top. I don't know why I wanted to show you that, but I thought the lawyers might enjoy that. Another cartoon, again, a weird looking guy, a person on a couch, and why medico-legal work is great, because I think I love working with lawyers. I hope lawyers and case managers enjoy working with me. We share ideas, we get to learn a little bit about how each other thinks, and plenty of time for questions, which is great.
Thanks very much for that, Nicole. Now, if people want to ask questions, they can either do so unmuting themselves and asking, or they can type it out in the chat, and I'm happy to read that out for Dr. Phillips. So are there any questions that people had in relation to the seminar or any of the points raised?
Hi, Joshua here from Comcare. Nicole, I just had a couple of questions in regards to a couple of things that you touched on in your presentation. Firstly, thank you so much. Very informative and really enjoyed it. My first question was just in regards to what you called your superpower and the impressions that you get from people when they enter the office. I just wanted your thoughts and comments in regards to obviously the current health climate and how a lot of IMEs have moved to online, and how you've gone and adapted your approaches to a telehealth type appointment.
Yes. Yep. Oh, yes. Look, that's a great question. And I think I was thinking of mentioning that at the start, and I thought I might run out of time. So I'm glad you've brought it up. I was concerned at the start because I love having people in my room for all the reasons that I've described. I like the energy. I know that sounds a bit pseudoscience, but it's really not. I like to feel what I feel, and I use what I feel to put together the assessment. I was concerned, but what I have found with telehealth is that it's actually been working really well. What we don't see are things like obviously how people are moving. If they're faking something, people come in and they're not moving a shoulder, and then they get up and they'll, you distract them and they'll walk off, pick up their bag. They say, they can't pick up anything with it. So you do miss that kind of thing. But I've actually found it interesting because you see other stuff. I've had people rock up to their IME in their beds. That's already quite telling. Sometimes you get a little look around at where they live and what's going on, and that can be quite telling if there's a lot of junk around, or you can pick up some other stuff. But I think that rapport can be just almost as well established online. It's just about taking that extra bit of time. I always spend quite a bit of time doing the introduction, explaining how the interview goes, and getting people comfortable. And that's going to happen whether they're in your room or online. I really do need to see their face, so I won't do any assessments by phone. I need to see their affect, and I've been able to, I think, do reports without too much difficulty, and I've been using it also with my patients, and that's been okay as well. So I think it's been good.
Perfect. Thanks, Nicole. And I guess my second question was just in relation to histories being provided, in terms of, you talked a little bit about GP notes and their importance and those sorts of things. But in regards to the letters of instructions that you're provided from lawyers and claims managers and the like, just your thoughts on the backgrounds that are provided and the information, whether it be too little or too much, or and how much that goes into your thoughts and your opinions, and how you formulate those compared to the actual medical evidence that's provided alongside.
Yep, I love that question too. I think that a really good summary of everything, particularly chronology and dates, is helpful, because look, I'm going to read all the information anyway, but if you've said, this happened this date, this happened this date, they had the meeting this date, they stopped work this date, they came back to work this date, they had the surgery this date, it's great for me to have that summary. So I really like that. I'm not quite sure how lawyers keep their files. I'd be very interesting to hear. But sometimes I get a ridiculously large file. Like a few months ago, I got one from a legal firm with 2,000 pages, which they've got to pay for my time to read, but a third of it was all pictures of scans. Now, I'm a doctor as well as a psychiatrist. I like to know scan results, but I do not need to see thousands of pages of pictures of MRIs. So just send me, you know, latest MRI result in writing. I find that interesting. I want to know that. So be sensible about what you're sending a psychiatrist. I do like to see GP notes, but you know, a summary is great, but sometimes, yeah, I do spend time trawling through them. And I found, look, it is a bit like going through people's dirty laundry, because you know, you're coming up with STDs and other things that you really don't need to know about, but it can be a wealth of information. Independent medical reports are also important to read. And I do spend time, I make sure that I go through the file completely before that person walks in my room.
Yeah.
Amazing. Thanks so much for that, Nicole.
Could I just make a few comments, if possible?
Please.
Yeah, firstly, Nicole, that was a fantastic talk. Thanks very much. Just a couple of things. I agree with the documentation issue. And more recently, post-COVID, there's been a lot of things sent online which are very tedious to follow, particularly when they're out of sequence. And I've often requested a hard copy within a proper chronology. The other thing, we have PERS in WA, and I've always felt that doesn't adequately capture psychopathology. And I've often had to say that despite this figure, this person is far more disabled, and it reflects their stoicism or their work ethic, etc. And I really feel there's a mismatch between a quantified PERS, and I'm not sure about the GEBIC, but I assume it's similar. But I really think it's an inadequate instrument, and often I have to provide some descriptive account of the functional impairment and try and, as best I can, quantify it. Just a couple other points, if I could. The issue of secondary conditions I've always found problematic, because I see people, as you would, with a classic mood disorder, which was generated and maintained by the chronic pain, which is directly linked to the index accident. And I've often felt that's unfair that people don't have that recognised, because there is a temporal sequence. It's usually fairly, that's variable, but it's directly related to the accident. And if not for the accident, that person wouldn't have MDD. The other thing is, I often see reports from unqualified people who, as you've already alluded to, diagnose PTSD with clearly no criteria that are valid, particularly fairly minor incidents, road traffic or bullying, etc. I get a lot of that, and I often have to stipulate that it doesn't meet criteria A1, and it's also, I find, kind of disrespectful to the people who've got genuine PTSD, who've seen grotesque injuries and dismembered people, etc. And it's become a bit of a black hole in medical legal work. And people, as you say, often will come along having read the DSM and say that I've got hypervigilance and this, that, and the other. And it's often not that difficult to actually discern what's going on in the symptoms, as you know, and often people will have nightmares that are variable and often not reflective of the actual event, but it's clearly connected with that. But I find that happens frequently. And the last thing with countertransference, I think it's an interesting point. However, some of our colleagues may have a degree of psychopathology, which may invalidate that countertransferential impression. With due respect, I've seen some reports where the person clearly was irritated or did dislike the person, and also people who I think often work for the defence, particularly in childhood sexual abuse cases, where it's clear that they've got a negative countertransferential impression, which then gets, which is reflected in the report. So I take your point, it's a very important instrument, but there's an assumption there. So, but thanks for your talk. I thought it was really comprehensive and very helpful.
Were there other questions from members of the audience for today?
Oh, can I just make another comment, Nicole, seeing nobody else is? Look, I agree with the DSM-5. It's a very political instrument, and it's connected with committees and all kinds of tribal conflict, because I'm aware of what happens in those meetings. With complex PTSD, and I see a lot of that with the historical sexual abuse, I've often used the ICD-11, which actually has now given complex PTSD, which was, I think, DESNOS. It had some qualification in the DSM-5, because it'll probably be in the 6. because I think it's important that these individuals who have had repetitive, chronic, severe trauma do present in a different way, particularly with the dissociative elements.
Yes.
And so I've often used the ICD and in court cases as well, quoting that, because the defence will often say, well, it's not a diagnostic category. And in
Yes.
fact, I think it came out in June 2019 or 20 in ICD. So I use that. I think it's quite helpful, particularly for that. And there may be other conditions as well.
Yeah, I mean, I agree. I think the DSM-5 should have been smart enough to put that in as a new diagnosis that they haven't had in before, because it is valid, real, we see it, and there's nothing else that we can use in the DSM to describe these cases.
Yeah, yeah, absolutely, yeah.
Did anyone else have questions for today? You can either put them in the chat or unmute.
Well, Nicole, can I continue then, seeing if nobody else?
Absolutely.
The other thing, with cases where there's particular acuity, would you correspond with the GP or somebody involved in their care? Because my view is that we probably, well, we should. I think that's our role ethically. So I've seen a minority of cases, but where they're clearly unwell and they need treatment, and in fact, some of them are at risk. And so I've actually directly contacted the GP and also notified the lawyers that should be done. I think that's, it's rare, but it does happen when you see somebody who you're particularly concerned about. Do you have a view on that?
So, well, I do have a view. Firstly, with respect to contacting their GP, I think that we need the consent of the client. And that normally comes in when we're requested to speak to the GP prior to seeing them. And I always want to make sure that I see that I agree to you doing this before I do this. So then it's more about, I've been requested to talk to the GP prior to seeing them to see if the GP has got any added information. In terms of afterwards calling the GP, that is not my role. That is not the role of an independent examiner. But what I will do is I will put that in the report, and I'll often highlight it so it doesn't get missed. Please send this report on to this person's general practitioner. There are important things here that the GP should be aware of with respect to diagnosis, treatment, etc.
Sure. Yeah. Yeah.
Okay, it's getting on 1:30. What I might do is we might finish up there, and if there are further questions, definitely feel free to shoot them through via email and I can pass them on. Nicole, on behalf of MAG and everyone attending, thank you very much. It was very informative, a great seminar as usual, and yeah, very grateful for your continuing contribution to the industry's education, and look forward to having you again on time sometime soon. So everyone, thanks for attending and have a great day.
Pleasure.
Thanks.
Thank you very much. Bye-bye.
Thanks, Nicole. Thanks. Bye.